Hey guys, this is Corey with Align Therapy, physical therapist here, talking about scoliosis all day long. That's what we do. So today we were looking at this x-ray of a past patient of ours, and you can see they have a right to left scoliosis right here, right on this side, left in the lumbar. And it was nice because this x-ray actually has the sagittal view as well, and something that we noticed with this patient while we were treating them, but it's also visualized here on the x-ray, is something that we call relative anterior spinal overgrowth. And what that essentially means is that the posterior side of the vertebrae in the spine is shorter than the anterior part. And that's actually a normal occurrence in a part of the spine that has a lordosis. You can see how, at least here in this lumbar vertebrae, this side is going to be a little bit longer than the posterior side. And up here, typically it's the opposite. So we'll have a kyphosis, which is this type of curve in the thoracic spine, and we'll have a shortening of the anterior part of the vertebrae relative to the posterior part of the vertebrae. So relative anterior spinal overgrowth in a scoliosis patient means that the anterior part in the thoracic spine actually ends up being longer than the posterior side, which can lead to a loss of that kyphosis. And we're going to look at how to measure that on here. So typically what you'll do to measure a kyphosis is you'll find the apex of the curve. And for us, this is a pretty difficult x-ray to find, but hey, it's real life, so we got to practice it. So I'm just going to take kind of the bottom of T1 here, and we're just going to kind of follow and see if that measures with the rhythm of that curve. And I think it does. So we're going to take the top of T1. Let's see, 1, 2, 3, 4, 5, 6, 7. T1's right here. Okay. So typically you'll find T1, the upper end plate of T1, and you'll draw your line. And this is important because when we typically measure a scoliosis, or sorry, a kyphosis in a sagittal view, we'll take T1 and we'll follow that all the way down until we get down to usually about T11, T12, and you'll look at the bottom or the lower end plate on that one until it starts to turn into lordosis here in the lumbar spine. So that'll be about right here because that starts to turn. And then we'll draw our line, and then we go home for the day because we did an awesome job measuring our kyphosis. You'd measure this angle here and you'd say, yes, they have a pretty average amount of kyphosis. But the problem is, if we look right, where is it? Right here, right there. That doesn't look like that's parallel. What happened? Well, it looks like we had a loss of our kyphosis. And so this doesn't tell the whole story. We would need to measure that loss of kyphosis right here, and that is caused by the relative anterior spinal overgrowth, which usually corresponds to the apex of whatever curve is occurring in the thoracic or lumbar spine. So right around T12, T11, this was the bottom of T11, I would say. I didn't actually count it, but thereabouts. And so right around the apex of that curve is where that starts to go a little bit awry and we lose a little bit of that kyphosis. The reason why that's important is because when we are prescribing exercises and someone has relative anterior spinal overgrowth, we really don't want to encourage even more lordosis into the kyphotic, into the thoracic spine, because if this continues moving forward, we all know what lies inside of the rib cage. We don't really want to compress on that. And if we're doing rows or bilateral external rotation, which is a common exercise for our patients, if if we're not careful, they're going to be really flaring their chest, bending their back, trying to really extend. And I think we can do better by just asking them to really make sure that they're anchoring their core, anchoring that rib cage down, to make sure that they do not do that, but they're still able to get a really good exercise of the target musculature. So just key things to think about when we're treating our scoliosis patients, and thinking about all dimensions of the curvature and how that should impact our exercise prescription, or just physical therapy prescriptions in general. So, I mean, you wouldn't want to be doing posterior to anterior mobilizations in this part of the back either. That wouldn't be a good idea. So, just thoughts for food for thought. Hope you guys have a great day. See ya.